Good evening, doctors. My name is Rakesh Sonone, and on the behalf of FDC and MedTalk, I welcome you all on the yet another and fresh episode of 52 Weeks Diabetic Essential by Dr. Sanjay Karla, President of South Asian Federation of Endocrine Societies. And as you know, we have launched a series of lecture on management of tropical fever, and we have a sixth lecture today. And the topic of today's lecture is rational use of antimicrobials in fevers. And before going to that, I want to announce last week quiz winners. They are as follows: Dr. Shantanu Kumar Bhattacharya from Kolkata, West Bengal; Dr. Ambar Agrawal from Hisar, Haryana; Dr. Gangadhar Rath from Bhubaneswar, Odisha; Dr. Shashi Khare from Bhopal, Madhya Pradesh; Dr. Hemant Adhikane from Pauni, Maharashtra; Dr. Javed Ahmed from Lucknow, Uttar Pradesh; Dr. Ramesh Hegde from Bangalore, Karnataka; Dr. Anand Purandare from Mumbai, Maharashtra; Dr. Kaval Saluja from Mumbai, Maharashtra; Dr. Pradeep Patro from Chhatrapur, Odisha; Dr. Satish Kumar Jain from Bangalore, Karnataka; Dr. Bharat Praveen Mitakola from Surat, Gujarat; Dr. Ashwini Kumar from Kanpur, Uttar Pradesh; Dr. Sanjeev Suri with Hoshiarpur, Punjab; Dr. Sumita Sharma from New Delhi. And with this, I want to hand over today's lecture to Dr. Sanjay Karla, sir. Thank you.
Thank you, Dr. Rakesh, and good evening, everybody. We've been talking about hot things, for the past 1.5 months or so. We've been talking about fever, about tropical fevers. Now, there are many types of fevers. You see, when we had Dr. Suneet Verma, he's an expert in Ishka Bukhar, so he's expert in many types of fevers. These days, we've had the G20 fever going on. But today, we have another expert for you and somebody who is expert in lots of hot things. And he is Dr. Navneet Agarwal. Warm welcome, Dr. Navneet.
Thank you, sir.
Dr. Navneet is consultant physician and diabetologist at Gwalior in Madhya Pradesh, a very well-known person in his field, and a person who is known for multifaceted personality. So whether it is singing, whether it is dancing, maybe public awareness, getting people to move, getting them to follow good physical activity and inculcate healthy habits in them, or whether it is hardcore academics. You name it, Dr. Navneet is there at the forefront. So, Dr. Navneet, for the past 1.5 months or so now, we've been talking of fevers. What impact does fever have on your OPD? What impact does it have on the satisfaction level of your patients?
In fact, when you talk of fever, I think in my 24 years of clinical practice, fever is the only disease which gives you shivers in the OPD. Sometimes you feel that it's just a fever writing a paracetamol, but sometimes when patient comes third and fourth time, fever is still persisting, then really you scratch your head and you are nowhere like what is the reason for this fever. So I think in the entire medicine, fever is the only thing which can give you a like you have to revise the entire medicine starting from just viral fever to any cause, anything, any disease which can be responsible for pyrexia of unknown origin. So
Hmm.
it seems just a fever, it's just a symptom, but there are endless causes. And when it comes to the fever, it gives you like sometimes even we get fever if patient is not getting relieved of the fever.
So there are some times when we underestimate the strength of fever. Like recently, we lost one of our close family friends. He presented with an innocuous fever. Uh, Everything was done. He was diagnosed to have aspergillosis finally, but he couldn't be saved. There were, of course, multiple other comorbidities as well. There are times when we underestimate, but there are also times when we overestimate. Like, for example, when we overtreat with the drugs, and then our patients get into trouble. There are times when we not only overestimate or underestimate, we do a parallel kind of an estimation. So one of my favorite songs, actually, it's a Haryanvi song. It's by Ajay Huda, and the song is Paracetamol. So what he says to the lovely ladies is कि तू मेरी paracetamol. When I look at you, all my aches and pains go away. So two questions here, Dr. Navneet, for you. First of all, what do you think of Haryanvi poetry? You are my paracetamol. When I look at you, all my aches and pains vanish.
So basically, this poetry is direct to the heart. He he is saying what he feels. There is no lag lapet sort of. Straight to the heart.
Yeah. Okay. And then the second question is, and this is what we'd like you to speak about. Can we use a drug like paracetamol in unlimited quantities for fever? And along with paracetamol, when we use antimicrobial therapy, what kind of stewardship, what kind of responsibility do we have for using rational, for ensuring rational use of antimicrobials? So over to you, sir.
Sure, sir. Thank you, sir. Thank you. Can I have the slides? So thank you, sir. At the outset, I wish to thank the IGCP and the FDC for giving me this opportunity. And it's always an honor and a pleasure to be introduced by my teacher, my mentor, my boss and guru, Dr. Sanjay Kala, sir. It's always a pleasure and it's a matter of pride for me to share the stage with him. So, as sir is, I think slide, okay. As sir has said that we need to answer the second question, that how we can rationalize the treatment use of antibiotics in the fever. Paracetamol, yes, we use off and on for the fevers, but do we really need to use antibiotics? That question has to be answered. We know that when it comes to the antibiotics, they are the most commonly prescribed drugs across the globe, and almost one third of the hospitalized patients receive one or the other course of antibiotics. And so, like if we talk of the volume, the antibiotics accounts for almost 40% of the hospital medicine budget. So they are not only the costing the medicine, but also costing the pocket of the patient. So, seeing the volume and the amount, we should rationally use the antibiotics because we know that the injurious use can adversely affect the patient and the cause it can cause the emergence of antibiotic resistance and also can increase the cost of healthcare. And not only nationally, but internationally and globally, many of the studies have shown that the irrational use of antibiotics is there and the proper use of antibiotics is still far from satisfactory. So that's why the ICMR has said that we should avoid antibiotics for low grade fever. As I was saying, that paracetamol can be used, but should we use antibiotics along with paracetamol for every fever? No. We know that the antibiotics from in the last century, there are multiple antibiotics, and the introduction of the penicillin has changed the level of changed the treatment of the infections. And in last 1 century, we have seen multiple antibiotics coming and helping us in treating the patients and managing the patient and correcting the infections. But there is a global epidemic of irrational use of medicines, be it misuse, be it overuse, be it use of injectable antibiotics, and that is really a cause of concern. There are multiple factors, not only in at the physician end, but also at the patient end. There are multiple factors which are responsible for this inappropriate use. Be the demand of the patient when a patient comes in the OPD and he says that I'm having fever for last 24 hours. Why don't you start with the antibiotic? Because anyways, after 2 3 days, if the fever is not corrected, I have to take the antibiotic. So better to start from today only. Though he might be suffering from only viral fever, we know that the viral fevers takes 2 to 3 days or 5 days to be ephemeral. So maybe because of the time conscious, maybe misconceptions about the antibiotics, maybe patient has some beliefs, and sometimes the economic concerns or the missing of the work. And at the level of the physician, there are real opposite pressure. Sometimes there are like self-economic concern or the economic concern, even sometimes the litigation. If suppose if I don't write antibiotic and patient doesn't improve, or patient might go to the another physician, and if patient has some complication, he may go into the litigation. And so there are multiple things, even the cognitive dissonance, that is knowledge but failure to act on it. So some factors, some patient factors, they might be responsible for inappropriate use. Sometimes the cost-saving pressure to substitute therapy for the diagnosis test. The patient, when the patient comes in the OPD, you ask the patient to go for an investigation like CBC or MPFM or the urine RM or even the blood cultures. Patient say, doctor, treat जांचे रहने दो, दवाई लिख दो. Anyways, 2 3 दिन दवाई खा के पहले देख लेते. So like there are multiple say patient factors or the patient demands. Reduce appointment time or the patient less effective. Even when we start a patient, we like it just a paracetamol patient has come to the OPD. and just for the fever, and we have started just a paracetamol as well as nothing else, no antibiotic, then patient says like, what you have written? So there are some patient factors, some the physician factors, sometimes even the industry factors, promotions of the antibiotics, and sometimes the social factors. So like there are multiple factors which are responsible for irrational or inappropriate use of antibiotics in fever. So, what is the rational use? As per the WHO, we should use the antibiotic for the right duration, first and foremost for the right indication, right dose, right duration, right route of administration, right frequency of administration. So we should we should provide a right information to the patient about the antibiotic. So as per the WHO, we should use antibiotic rationally to avoid the resistance, to avoid the complications to the patient as well as to the society. So when we are choosing an antibiotic, there should be some questions in our mind. And what questions we should ask while prescribing an antibiotic? Is an antibiotic necessary? What is the most appropriate antibiotic? What dose, route, frequency, and duration are needed? And is the treatment effective? So let's see them one by one. First and foremost, we should decide whether writing or prescribing an antibiotic is necessary to this particular patient in this particular situation, because we know that not all fevers are due to infections, and because like many of times they might be because of just an inflammation. So fever is just a symptom, it's not a disease. Fever might be reflective of infection, fever might be reflection of the inflammation. So there are multiple reasons for the fever, and all not all infections are caused by bacteria. We know that viral infection, we know the fungal infection, so there are multiple other causes for the infections also. So not all fevers are due to infections, and not all infections are caused by bacteria. We know that the common viral infections, there is no need of antibiotic, and even if there is a bacterial infection, many bacterial infections they resolve spontaneously. And we should see that where the infection is, because like just a superficial infection may be corrected by a local antiseptic or local antibiotic application, doesn't need a systemic antibiotic. So we should be thinking that whether prescribing an antibiotic is necessary in this particular patient or in this situation. Then second is choice of an antibiotic. Successful therapy of any infection, it depends on the correct choice of antibacterial, and a correct choice of antibiotic needs three factors to be considered. First, etiological agent, second, the patient, and third is the antibiotic itself. So what how to decide about the etiological agent? Not necessarily that we are going for a blood culture or urine culture or culture sensitivity for every patient. Whosoever is coming to our OPD for just a infection of 1 day or 2 day, and we are going for these blah blah investigation. Not necessary. Depending on our clinical acumen, if needed, supported by the lab reports, we can think of what might be the etiological agent in that patient. Many times, even we are without doing any lab reports, we prescribe antibiotics based on our clinical acumen, and which we call it as empirical therapy. So, as a physician, as a clinician, we should have a knowledge of universal and local sensitivity patterns which can help us in choosing the correct antibiotic. Even where a bacteriological report is available, we should interpret it cautiously and wisely, because there are multiple factors even in that report, like the timing and of the collection of the sample, procedure of the collection of the sample, and the transportation of that sample for culture sensitivity. So, etiological agent to think about the cause, to think about the pathogenesis, to think about the microorganism. We should be using our clinical acumen whether this might fit into this particular patient or this particular situation. Then the patient. In the patient, we should have the consideration of the various factors like the age, the comorbidities, the presence of the immunodeficiency, presence of diabetes or any other disease. So, like age, we know that the young patient or very young patient and elderly patient, we should be choosing antibiotic cautiously, because in elderly patient we might have a renal impairment. They may develop nephrotoxicity even at the lower doses. They may have an allergic reaction. Then we should see for the any hepatic or renal derangement, so that we can reduce the dose or we can choose the dose wisely. Then some genetic factors. Some patient might respond to that antibiotic different way. Some patient might respond to that antibiotic in a different way. So there might be some genetic factors which are playing a role in the response to the antibiotic. And then history of allergy to the antibiotic. We see very commonly in our OPD, the patient comes and say that I'm allergic to sulfur drugs, I'm allergic to penicillins, I'm allergic to this drug, I'm allergic to that drug. So we should be thinking of the common antibiotics or the common allergies to some particular antibiotics. Third is antibiotic. Whenever we are choosing an antibiotic, we should have in our mind the pharmacokinetic properties, like whether it is orally absorbed, what is the viability, what is the route of metabolism, what is the place of metabolism, where it is metabolized, what is the route of excretion, and then its ability to cross the blood-brain barrier, whether this particular dose will able to achieve the therapeutic concentration, and whether this concentration is achieved at the site of infection. And then finally, what is the drug-drug interaction with the other drugs or the drugs which are we are prescribing to that particular patient, whether it will have some interactions. Then the frequency of the antibiotic or the frequency of the dosing frequency, it is once a day, twice a day, thrice a day. Then what is the route of administration, what will be the duration of therapy. I'm sure you all must have seen that whenever you prescribe any antibiotic to a patient or even us, when it is prescribed for 5 days, usually the patient they take when they stop the medicine when they become asymptomatic, particularly in terms of prescribing a combination of oflux, not at all for the gastroenteritis. The cost of the antibiotics is also a major concern. We should choose wisely. We should choose cautiously the costliest antibiotics or the broad spectrum antibiotics. So when should antimicrobial be used? Sorry, empirically. Empirical therapy is initiated targeting potential source of infection, and particularly when we are thinking that the situation is might serious and we can't wait for a culture sensitivity, we can't wait for the lab reports. So an understanding of the surrounding epidemiology is especially important, and the need to administer antibiotic early in the clinical settings like the sepsis, pneumonia, meningitis, or some serious infections. We should seriously starting antibiotic empirically, not waiting for the lab reports. We should assess the vulnerability of the patients. What are the comorbid conditions? Whether it is acute or chronic organ dysfunction, immunocompromise, drug interaction, and the socioeconomic status we should keep in mind. There are some useful clues to support targeting of the empirical antibiotics, identifying probable site of infection, which pathogen are most likely, and if multiple antibiotics are to be administered, consider first giving the antibiotic most likely to attack the offending organism, with guidance from the system-based reviews. So it is just a brief outline, like if what system you feel that it is affected, what can be the probable disease, and then you can empirically start with the antibiotic, waiting for the culture sensitivity, waiting for the specific reports. So like if it is a meningitis, encephalitis, you can't wait for the report. You have to start empirically with the coverage of all the spectrum. But suppose if it is just a URL, it is just a sinusitis, if it is just a pharyngitis, you should think whether the patient really need antibiotic or it is just a self-limiting disease. If the patient is having a lower respiratory infection, then we should think of that whether it is a community acquired pneumonia or it is a hospital acquired pneumonia. If it is community acquired pneumonia, then definitely we have to choose empirical therapy based on the presence of the the causative organism in that community. And if it is antibiotic hospital acquired, then definitely we know that it might be a serious infection. It might need a broad spectrum. It might need a higher antibiotic. So depending on the clinical sense, we can start empirically antibiotics when the situation warrants. So these are the quiz questions which we will take in between. Which of the following terms refers to the ability of an antimicrobial drug to harm the target microbe without harming the host? A. Mode of action. B. Therapeutic level. C. Spectrum of activity. And D. Selective toxicity. What we call as ability of an antimicrobial or antibiotic to harm the target microbe without harming the host. Only harming the microbe, but not harming the host. I think everyone has seen the question and the choices. Can I proceed to the second question? So, and second question is, which of the following has yielded compounds with the most antimicrobial activity? Which of the following water, air, volcanoes, and soil. Compounds with the most antimicrobial activity. हमारे पंच तत्व, पृथ्वी, जल, आकाश, वायु. So, which of the following has yielded compounds with the most antimicrobial activity? So we've seen that the antibiotics are precious, and definitely we need to preserve them to avoid such type of news. That this is the news from 2019. So we need to preserve the antibiotics to preserve the society, to protect the society. And for that, there are multiple guidelines from the different stakeholders has been given to adopt the enabling treatment guidelines, and WHO has given the 12 core interventions, a mandated multidisciplinary national body to coordinate medicine use policies, clinical guidelines, essential medicine list based on the treatment of choice, drugs and therapeutic committees in districts and hospitals, problem-based pharmacotherapy training in undergraduate curriculum, containing in-service medical education as a license requirement, supervision, audit, and feedback, independent information on medicines, public education about medicines, avoidance of perversion, uh, financial incentives, appropriate and enforced regulations, sufficient government expenditure to ensure the availability of medicines and the staff. So these are just recommendations to promote a rational use of medicines by WHO. So, to conclude, antibiotics are the lifesaver, we all know, in case of infections, and they have really changed the course of the treatment when a patient is sick, patient is serious, and patient is critical, particularly with an infection. So, we should use judiciously, critically to avoid resistance, because we have seen that no major new class of antibiotics has been introduced in last decade for a clinical use. And believe me, no antibiotic is resistance proof. No antibiotic is resistant proof. You can have resistance to each and every one of antibiotic, maybe not today, maybe in coming decades. So the dictum is how long an antibiotic will remain to be useful. It depends how it has been used. Thank you very much for the patience here.
Thank you, Dr. Navneet. Wonderful talk. Thank you so much. You've talked about rational use of antimicrobials, and you've also explained the reason why we need to protect these antimicrobials so that protect them from irrational use so that they can continue to protect our patients. What
Yes.
are the common errors that you see in your OPD around you? Let's try to classify these errors first of all. So maybe errors of diagnosis, errors of prescription, errors
So
of errors of uh, actually making sure that errors of delivering the drug. You know, if the drug is delivered in a wrong manner. So can we just talk about the various errors that you see?
yes, so errors is they start from the patient end only. Patient comes to us in the OPD, say like a fever of 3 days, 4 days, and he has tried 2 3 antibiotics of his own. Like he might be having some remaining medicines at his home of the last infection, maybe 3 4 months back or 5 months back, when he was prescribed some antibiotic. They are remaining at his home. He has taken those antibiotics like 1 dose or 2 dose. Sometimes even the antibiotic would have been twice a day. Patient is using once a day, क्योंकि हमारे इंडिया में ना गर्मी बहुत करती है दवाइयाँ. ये बड़ा कॉन्सेप्ट है, दवाई गर्मी करती है. So like when you prescribe them twice a day, they'll take once a day. Even it happens even for some medicines of chronic disease. So patient usually they have tried one antibiotic of one sort, like they have started taken one levofloxacin, one azithromycin, क्योंकि घर में एक ही गोली बची थी. And now third day they are still febrile. So patient has done. So sometimes it is patient factors, and at our end, at a physician end, because like the patient when comes to the 2 3 days of the fever, we write some investigation or we prescribe some investigation. The investigation report might be available maybe next day, but that time you have to write some empirical antibiotic. So again, we have started a third same antibiotic or third antibiotic, because like sitting in the OPD just writing a paracetamol to a patient on a prescription, patient is not very happy because like, he feels कि मैं इतनी दूर से आया, इतनी फीस दी और क्या लिखा इन्होंने, and just investigation. So like even sometimes you feel pressurized to write the antibiotic. For that, you might feel that it is just a viral infection and patient needs to be just counseled. Patient needs a reassurance. And then the culture sensitivity reports are available after 2 days or 3 days. Then only you can advise antibiotic as per the culture sensitivity. But it's not possible because they are not very cheap investigations. So many of times in our OPDs, we have to prescribe empirical therapy. And the problem in India is that antibiotics are available over the counter. Even the retailers staying nearby to the patient, or patient is staying in that locality, they are the doctors for the first antibiotic use. They prescribe amoxicillin, ले लो, ये ले लो, वो ले लो, और 3 दिन खा लो. And sometimes even they don't tell कि like azithromycin, it has to be taken before meal. Patient को लगता है गर्मी करेगी, तो they take even azithromycin after the meal and it is not getting absorbed. So there is no one, like, because the right information is not available with the patient if they are doing this self treatment.
Dr. Vinayak Sharma greets you, and there is a question. Along with antibiotic stewardship, is there a role for steroid stewardship? How frequent is it that steroids are used or misused for the management of fever?
In fact, in my experience, steroids are 19 more than 90% misused, not properly used, because like antibiotics are not indicated for fever. There is a specific subset of the situation and the condition where you need steroids for that fever. But in the rural areas, there is a concept, because whenever in the rural areas like the quacks or the RMPs, or they are giving injections, so they give injectable antibiotic. The preemptive Avil and Decathlon are given just to safeguard is a reaction now.
Hmm.
They give prophylactically Avil and Decathlon while giving the IV fluids along with some antibiotics in the drip, particularly in the rural area. So the steroids are overused and misused. Majority of them they are misused for fever.
There is another question, sir, and this is regarding rational use of antifungals. So now, in persons with diabetes, melanoposthitis and pruritus valvae have become common. Number one, diabetes is increasing. Number two, poorly controlled diabetes is increasing. It's occurring in younger people who are more sexually active and maybe hyperactive at times. And also, there are some drugs which predispose to these infections. So, any comments about rational use of antifungal therapy, especially keeping people with diabetes in mind?
So in fact, there is a very common concern that people use all these antifungal creams, and they're commonly available in every household. Local or the topical antifungals are fine, but now people have started taking oral antifungals. Ideally, sometimes even just by maintaining the urogenital hygiene is sufficient. Not necessarily that every pruritus needs antifungal orals or the systemic antifungals. Sometimes just by a local hygiene, by you can manage this, or even just a local applications. Not necessarily every diabetic having a pruritus or the genitourinary tract infection needs antifungals. They're also again overused.
Hmm. One last question, sir, if you allow, and this is regarding OPD use of antibiotics. So, supposing I'm working in periphery, patient comes in with fever for 5 or 6 days. Patient has been behaving very well in the sense he or she did not go to the chemist, did not take any antibiotics, has been taking paracetamol round the clock, but fever is not coming down. Clinically, I can make out it is not malaria. Patient has got continuous fever. The tongue is coated. Now, beyond this, I cannot do any other tests because they are not available in my primary healthcare center. What antibiotic or what antibiotics would you suggest? Coated
So like
tongue, fever for 5 days, no
yeah,
test available.
yeah. So, like the fever is still for 5 days. That means it is not just a viral fever. One, and patient is taking continuously paracetamol. Patient is not responding, and you have pointed that clinically the tongue is coated. That suggests a very common enteric fever in our OPDs and all. So, commonly used antibiotics, which we know that from the local knowledge of our this we can say the geographical area. So, we can use say empirical therapy in this type of patient, antibiotic which we know that is effective for the enteric fever. We not necessarily go for any investigation, as you said that the antibiotic the investigations are not available. So you can choose empirical therapy, antibiotic therapy in this patient who still has a fever after 5 days and the tongue is coated. Then definitely needs antibiotic.
And like Dr. Navneet said, it will depend upon what is being used in your geography. So here in Northwest India, perhaps ofloxacin and azithromycin
Yes.
combination would be the first line. And make sure you give adequate doses of both.
Yes.
Don't
And for the
reduce the
adequate
dose.
duration. and
Yes.
adequate duration.
Yeah. One more challenging situation Dr. Suresh Shukla shares with us. He talks about a 73-year-old gentleman with type 2 diabetes, fever, arthralgia, and arthritis. Patient continues to have arthralgia even 2 months after the arthritis. Steroids were given. Patient was treated as chikungunya. Now, patient is on hydroxychloroquine. Mild fever is persisting. All the tests are normal except ANA, which is weakly positive. So, does this mean it is an infective fever? Does it mean it is a non-infective inflammatory fever? And what is the role of HCQ, hydroxychloroquine, going forward?
So in fact, like if it have been an infective fever for last 2 months, it cannot be. If it is infective, definitely you will have the severe consequences. So like it is, as you suggested, it is a mild fever and it is persisting for 2 months. It is all inflammation, or it is because of the autoimmune disease, and the patient has an ANA positive and the arthritis. So arthritis or any autoimmune disease, they are all associated with the low grade persistent fever. Hydroxychloroquine is given for the arthritis, not for as an antimalarial. It is given for the arthritis or arthralgias.
Hmm. And Dr. Suresh, since it is non-infective, no point in giving antibiotics. Already you have
Antibiotic.
mentioned that. And if he's 73 with type 2 diabetes, steroids should also be given with a lot of caution.
Ideally, not to be given because already 70, more than 70 years of age,
Hmm.
and diabetic.
Osteoporosis, hyperglycemia, other infections may come up. Also, note that if your patient has to be on steroids, usually with prednisolone, methylprednisolone, the highest glucose levels will be after lunch or before dinner. So, don't miss those glucose values while monitoring. Do check for post lunch and pre dinner glucose. If they are high, you have to add something at lunchtime also, whether a tablet or injection.
And even if it has to be given the lowest possible dose,
Yeah.
ideally lowest possible dose in the morning.
So just like we have antibiotic stewardship, we also have antifungal stewardship and anti and steroid stewardship. So thank you, Dr. Navneet, for touching all these aspects.
Thank
It's
you.
been great being with you, Dr. Navneet. Thank you so much for your insight. We appreciate the enthusiasm with which you have shared your experience and expertise. And we
Thank
thank you
you.
for all your efforts in improving the education level of all of us across India. I would
Thank
also
you.
like to thank Mr. Anang Basu, who is the driving force behind Diabetes Essentials, a very humble person, a very quiet, down to earth person. So, Mr. Basu, thank you so much. We've
Thank you, Dr.
been
Basu.
yeah, we've been working on Diabetes Essentials now for 3 years. This is the third year going, and Mr. Basu travels across the country. One nice thing is, for those of you who know him or you don't know him, he is equally at ease in the metros of the country and equally at ease in the districts and talukas and villages of the country. He will happily travel all across India. And it is he who came up with the idea of talking about tropical fevers because he saw that doctors are facing this challenge. We'll be continuing with this series of tropical fevers for another 4 weeks or so. And next week, our topic will be evaluating tropical fever of 3 days duration. This will be taken by Dr. Suneet Verma. The week after that will be a very hot endocrine topic because the topic is endocrine fever, endocrine causes of fever. Then we go on to another topic which Dr. Paritosh will take, that is evaluating a fever of 7 days duration. And we conclude this series with diabetes and fever 4 weeks from now. And then we go back to our diabetes essentials agenda. But Mr. Basu, thank you so much for taking care of all of us so that we are able to take care of other people. Your comments before we conclude for today.
Sir, the whole idea is yours, and you have already picked up the right speaker for the right sessions, which you have already designed, sir. We are only the facilitators because we know that this is the season which is continuously in India. We are facing a lot of tropical fever, and there are a lot of cases now which is going undiagnosed also that we have seen last week session, sir. And yesterday, sir, I was meeting a physician in my town, Bardhaman city, sir. And actually, I remember that doctor calling the local path lab because he was suspecting UTI and the test was not clearing anything suggesting to that, sir. He actually called in front of me and he was discussing that, sir. So that's the and he's a regular watcher of our series, sir. That's why, sir, I keep on saying that the message which we are percolating from these sessions are actually going down the line to treat the patients well, sir. So thank you, Dr. Sanjay Kalra, for actually making these sessions ongoing. And for last 3 years, he is with us every Sunday, making us helping our patients treating well, sir. Thank you, sir. And about Navneet, sir, I would always say that he is the one who brings all the energies, and that's why, sir, last time when we requested him to be there, and whenever we find topics which is close to diabetes and something close to clinical day-to-day operations, we always get Dr. Navneet Agarwal from Bundelkhand, sir. Thank you very much with once again,
Thank
sir.
you, Mr. Master.
Navneet, sir.
Thank you for the nice words. And it's always a pleasure to learn from Sanjay sir,
Yes,
my
sir.
teacher,
Dr.
my
Navneet,
mentor.
yeah. One question from Dr. Bishwajit Haldar. Sir has irritable bowel syndrome and diabetes. His question is, can I use prebiotics, probiotics around the year? And can I use it along with pantoprazole, domperidone?
So prebiotics, probiotics, yes, he can use, but we know that if he's using pantoprazole around the year, then definitely it will reduce the good microbiota in his gut. So preferably he should judiciously use PPIs. As we are discussing the judicious use of antibiotic, there is always a judicious use of PPI because they alter the microbiota of the gut. So yes, pre and probiotic you can definitely use. And while using PPIs, you should consider that if he don't want it to be regular, he should not.
So try to reduce pantoprazole, domperidone. Some days you might be able to manage with domperidone alone. You can also sometimes use ribamipide, which is a cytoprotective drug that will help you reduce the need for PPIs. Because ideally, PPI should not be prescribed more than 8 weeks, and at the most 16 weeks. We should not be giving it more than that. But regarding your question for pre-probiotics, actually you should take that. The pre-probiotic will reduce the possible side effects of pantoprazole. So
Yes.
actually, that is the help that it will give. So thank you, Mr. Basu. Back to you again for the vote of thanks.
First of all, I sincerely thank Dr. Navneet for taking this session's uses of and judicious uses of antibiotics, and at the same time, I sincerely thank Dr. Sanjay Kalra for being with us every Sunday. With this, already three topics have already been discussed with Dr. Sanjay sir, which we will be continuing till I think on the sir, we have taken up to 8th, right, sir? 8th of
Yes.
October. So we
October.
will be continuing our diabetes essential. Under that, we will be taking this tropical fever, and two sessions of diabetes will be coming so that we continue from there to our diabetes essential. With this, sincerely, I thank Samdar sir and Navneet sir. Good night
Thank
and
you.
Jai Hind, sir.
Thank you, Basu.
Jai
Thank
Hind.
you. Thank you, sir. Namaste, sir. Pranam, sir.
Namaste, sir.